Hello everybody, I am Teresa Amaral, head of the Skin Cancer Clinical Trial Center at Tübingen University Hospital in Germany, and I'm here directly from ASCO 2025 to discuss with you a couple of works that have been presented here and I think are important for you to know about it and also to discuss. So we are already in the 1st of June today, but actually until yesterday it was the Melanoma Awareness Month, or Melanoma and Skin Cancer Awareness Month. And I think it's interesting that one of the posters and one of the works that have been selected to be discussed here and presented was associated with strategies and interventions to prevent melanoma and other skin cancers, namely preventions or works and interventions that have been done in kids and young adults in order to prevent this skin or this UV exposure. And this is something that you don't see a lot. It's talked a lot, but these kind of interventions are not very common. And it's very interesting to see that this has been selected to be discussed here. Well, that was part of the prevention, and now we go to the early stage melanoma. As you can imagine, and as you probably know, the majority of the patients that are diagnosed with melanoma are actually diagnosed as early stage, and this means stage 1 and stage 2. Being the majority of the population that is diagnosed with melanoma, it's also the population for which we don't have a lot, or no, we don't have any approved therapy, especially until stage 2A. What can we do to these patients? And there have been a couple of works being presented here at ASCO using artificial intelligence to look into slides from patients and from primary tumors of patients diagnosed with early stage melanoma. And actually these have been pretty promising on predicting the risk of recurrence of these early stage patients. In the transcript of this video, we will also get the numbers of the posters, and you can get more information if you want to look into more detail on the data that has been presented. Another work that I would like to call your attention for which I definitely have some bias because it's the poster that I presented here. It's a gene expression profile also using the primary tumor of patients diagnosed with early stage melanoma, so stage 1 and stage 2. The majority of the patients were stage 1A. And we looked into this primary tumor and we tried to identify who are the patients that are at higher risk of developing a recurrence without having the information of the sentinel lymph node biopsy. This is one of the ways to look into this population, looking into the ones that have high risk, but also looking into the ones that have low risk and can safely forego other evaluations or other interventions like further follow-up, skin checks, ultrasounds, and blood tests, and so on. Again, the number of the poster will be in the transcript, so you can look into that into more detail. Then moving into the adjuvant setting, for which we already have some data. What is interesting, or where we already have some therapy that is reimbursed. So for stage 2, we have immunotherapy. For stage 3, we have immunotherapy and target therapy for the patients that are BRAF mutated. And some of the data that has been presented here is looking into different ways of not only clinical data, but also gene expression profile, NGS, and other assays like ctDNA, and combining the information of all these, combining all this information to try to understand who are the patients that are going to recur, and if we can see it from the very beginning, also on those patients that received adjuvant therapy. And these are a couple of posters looking into this, showing that in principle and based on this data, we might not have just one biomarker that can tell us these patients are patients that despite of the therapy will recur, or these are patients that under therapy will have a benefit. Interesting enough, we also have other trials being presented on Tuesday, and we'll have another session looking into detail into this trial data that are looking into target therapy in the adjuvant setting, and this is the Columbus-AD study, and also a negative trial that is the BMS trial, the 098, that looked into PD-1 versus PD-1 plus LAG-3 in patients in stage 3. I think this is a very important trial, and it's important that these negative trials are also presented and are desiccated so that we can understand what are the patients that really don't benefit and what can we use from these trials to move forward the investigation. Another interesting poster that has been presented here is looking into patients receiving adjuvant therapy with immunotherapy or target therapy if they are BRAF mutated. Why is this poster interesting? Because I would say that there is some conflicting data on what type of therapy you should use in the adjuvant setting if the patients have a BRAF mutation. And there are some retrospective data showing that target therapy upfront might be better. But the poster presented here shows that immunotherapy actually seems to do better, although the majority of the patients were indeed treated with immunotherapy and not target therapy. And I think this real-world data and this retrospective data are more important every day, because we will not have any trial that will look, or I don't expect to have any trial in the future, looking into adjuvant target therapy or immunotherapy for stage 3, for patients with stage 3 melanoma. And besides the BRAF mutation, we will definitely need other biomarkers that will help us to guide our decision for patients that have this BRAF mutation and have a stage 3 melanoma. Then moving into the advanced setting, the most important questions that we want to get answered are not what we should use in first-line therapy, because this is, I would say, pretty clear for the majority of the patients. And we have data from the SECOND-BEAT trial, we have data from the DREAMseq trial saying that patients will probably benefit more from immunotherapy upfront, even when they have a BRAF mutation. Very particular patients will require or will be candidates for having target therapy up front, as the majority of them will receive immunotherapy. And this is exactly the data that is going to be presented on Tuesday from the DREAMseq study. And the data will show that after 5 years, that is almost twice higher overall survival rate in patients that started with immunotherapy, and 3 times better PFS for patients that started with immunotherapy as compared to target therapy alone. There are some nuances from this trial, because not all the patients that started with immunotherapy or target therapy did the crossover. Many of them because they had brain mets, and this was one of the exclusion criteria to do the crossover. But still, it shows that apparently to the majority of the patients you should start, if possible, with immunotherapy in first line. Interesting is to understand what do we do into patients or for patients for which we don't have a benefit using PD-1 therapy. And there it comes the second-line therapies and more, I would say, experimental data on other strategies that include also cell therapy and tumor infiltrating lymphocytes, the non-TIL therapy. And there has been presented some data as a poster showing that indeed patients that receive TIL therapy have a good long-term outcome after 5 years after this therapy. So this might be a therapy that is possible to be given to a specific subgroup of patients and a very selected population. And also interesting is to look into the same strategy without using the lymphodepletion that is normally associated with this type of therapy, and the interleukin-2 that is also given, because this is first one of the limitations to select the patients that will get to this therapy, and second, one of them, or these 2 therapies are the ones that are responsible for the majority of the toxicity that we see with this therapy. So really interesting data to see how we can bring this therapy to our patients, but also how we can do it with reducing toxicity. Finally, one of our other treatments that have been discussed here and will also probably come in our future discussions are treatment-directed therapies, so local therapies like local injection therapies and viral therapies, which kind of have been pushed again or have been coming again in the scene with new data from different type of viral therapy, but also with a combination of PD-1 therapy, which I think are quite interesting because they are looking into patients that really did not benefit from PD-1 therapy. So for the future, this would be my two populations or three populations where I think we need to have more data, and we should definitely invest more in the future trials. The first one for early stage trials, and again looking into trials that are biomarker selected. I don't think we can go on doing adjuvant trials in all the population of patients with stage 2 and stage 3. Patients that did not benefit from PD-1 therapy in the advanced setting, but also those that received PD-1 in the adjuvant setting and did not benefit from that, and patients with brain metastases, which are obviously a difficult to treat population for which we don't have a lot of options. Finally, some posters also analyzing treatment for patients with acral melanoma and mucosal melanoma, which again, it's a population that normally is excluded, and it's nice to see that some companies are still investing on that, and also some retrospective data showing that despite the fact that the patients do not benefit as good as or as much as the patients with normal cutaneous melanoma, there is still plenty of space to investigate new treatment avenues for these, I would say, not rare patients or not a rare population, but a population normally is excluded from clinical trials. And this was my summary from what we know so far from ASCO 2025. I'll get back to you with the second take on this interesting meeting when we have the late-breaking abstracts presented in the rapid oral communications and also in the oral communications, which I think might come also in hand when you want to decide what to do to your patients in the clinics next week. I hope you enjoyed the meeting and looking forward to see you again soon. Thank you.